Hello, everyone. I'm Dr. Carmen Pugliafito, and today I have with me Dr. Veeral Sheth of Chicago. Veeral, welcome back to
Thanks,
Retina
Carmen.
Science.
Thanks for having me back. Always fun to be on the show.
So, exciting developments. You were the first author on the Rhone-X study paper, which was published in Ophthalmology within the last 2 months. And it was a long-term look at faricimab and diabetic macular edema. The results were impressive.
Yeah. Thanks for kind of highlighting this, Carmen. Yeah, I think certainly proud of the work for sure. This was a global, phase three trial, lots of study sites around the world, and a really long study. So it's really the longest and largest study of its kind, looking at DME patients. Um, 2 year open label extension is really kind of what we're talking about in this paper, which is known as Rhone-X, which is really an extension of the core studies, Yosemite and Rhine. And Yosemite and Rhine, we've been talking about for years, but this was actually now 2 years beyond those studies. So everybody that was eligible and that wanted to roll over into this extension from Yosemite and Rhine that had received 2 years of treatment for DME could now roll into 2 years of essentially treat and extend with faricimab treatment. And so, really, that's kind of the gist of the trial. With these types of extensions, the goal is to, roll over as many patients as we can, which we did in this trial, and to get a long enough look so that we can really get good safety data. I think a lot of these extensions really are primarily looking at safety. And so, let me know where you want to go. We'll dive in to the data if you're ready.
Yeah, I mean, how many patients were involved? It was
Yeah.
large.
So in the core studies, Yosemite and Rhine, there was 1,891 patients. So they kind of finished the 2 year trial. And then 91% of them rolled over into the extension. So
Wow.
that was 1,474 patients. And again, so if you look at the core study, it's really important to kind of highlight what were the groups in the core study. Patients either received faricimab 6 milligrams every 8 weeks, faricimab six milligrams treat and extend, or the comparator arm, which was aflibercept 2 milligrams every 8 weeks. And so all three of those groups, if you chose to roll over into the extension, you got the faricimab kind of treat and extend protocol. And so everyone was then kind of on the same kind of treatment protocol, which is neat to see because not only do you have people that are on faricimab for 4 years, but you also get that switch group, which is a aflibercept for 2 years, and then switch them over to faricimab and see what happens.
So the total study period was how long?
So 4 years total.
Wow. So
Yep.
the rollover period gave you some real world data.
Yeah. Yeah. I mean, these like we know because now we have so much good real world data with faricimab, like the Truckee trials and far retina and far wide. And most of those patients, at least in the very beginning of all those trials, real world studies, were switch patients, right? They were switch patients, and the vast majority of those were either getting switched from aflibercept or bevacizumab, and most of them are aflibercept. And so you really kind of get that in a well-controlled environment here because a third of the patients in the core study were aflibercept every 8 weeks, and now they get switched over to faricimab.
So what were the study results?
Yep. So again, first and foremost, we're looking at safety with these extensions, right? And what we saw in the extension was what we saw in the core studies, and which matches up with what we're seeing in the real world, which is faricimab is well tolerated now through 4 years in a lot of these patients, and the safety profile is consistent with Yosemite and Rhine trials. And I think the thing that everybody wants to know, zero cases of retinal vasculitis or retinal occlusive vasculitis. So again, in line with what we're seeing in the real world, reassuring. Now we've had patients that have been on this treatment for years and they're doing really well. So that's okay. So that's safety. Then we also obviously secondary endpoints are going to be looking at anatomy, vision. So from a BCVA standpoint, really good reassuring data that those 10-letter gains that we were seeing in the core trials persisted into years 3 and 4. In other words, you switch these patients over or that you continue them on faricimab, and at the end of 4 years, these patients are gaining somewhere between 9 and 11 letters at the end of the day. And then CST, right? really robust drying effect that we're seeing with faricimab, and that continues on into years 3 and at the end of the year 4. So again, about 200 microns of drying effect that we saw at the end of the 4-year study. And then the last thing, or one of the other things we look at is durability, right? So durability, the question is, how long do these treatments last? We're getting some of that data in the real world. But at the end of this 4-year study, the question is, well, how many patients got out to 12 weeks or 16 weeks? And so the answer is about 80% of the patients were extended to 12 weeks or longer intervals. And if you look at the 16 weekers, it's about 65 to 70% of patients that got out to 16 weeks by the end of the 4th year. So again, really good durability data that we're seeing.
Wow. Um, how many injections on average did patients have on an annual basis in the rollover period?
Yeah, so that's a really great question. So, again, remember they're treat and extend. And so the question is, in years 3 and 4, how many injections are patients getting? And the answer is, on average, in those 2 years of the extension, around 7 to 8 injections, right? So somewhere around 3 or 4 in that year 3, and about 3 injections in that 4th year, right? So they're extending out. We're seeing good durability. And then obviously, if you're doing that, you want to see, does the vision remain kind of sustained in terms of the BCVA improvements? And does the anatomy remain stable? And the answer to both of those, going back to what I was saying earlier, yep, good BCVA results, nice dry retinas, few injections, right? So that's a kind of a key endpoint that we were looking at.
What do you think happens beyond 4 years?
Yeah,
Are we
it's a
going
good
to
question. I
have,
mean, so now we have patients, and Carmen, having had these patients in these trials, I mean, we have patients that are into year 5 and 6 of their treatment now, right? Because they graduated from these studies and now have been in the real world for a couple of years. So I can tell you that these patients are doing really well in terms of safety, in terms of disease stability, in terms of durability, right? So I think you can get, even further and further between your injections in the real world after a while. And so I think that that's a kind of a nice thing that we're seeing kind of evolve in the real world data as well. The other thing that I think was important in this trial, kind of going back to your kind of what's happening in the real world, is one of the things that we were interested in is that switch group. Okay, so what happens to the aflibercept group at the end of that second, at that set 2 years? So they've gotten 2 years of Q8 weeks of aflibercept, and now they switched over. So the question is, how many of them were absent DME, so they didn't have any fluid left at the end of the core study, and then what change did we see after they switched to faricimab? So at the end of 2 years, the first 2 years, the aflibercept group, 82% of them were DME free, let's call it, versus somewhere in the 90-94% range of the faricimab group. So the aflibercept group had a little more fluid at the end of the core study. So those 82%, now the question is, you switch them over, and for 2 years they get faricimab, treat and extend. What percentage now are DME free? So you started at 82%.
yes.
The end of that extension, 95% are fluid free, DME free. So
Wow.
even that group, that, let's call them like the more difficult to treat
Yes.
patients, we have these in our clinics, we see them all the time. When they got switched from aflibercept to faricimab, we got even more of these patients dried out. So again, reassuring, we get new treatments, we want them to work better, we want them to dry better, we want them to last longer, all of that. And so we were seeing that here in the extension.
So for our audience, what's the protocol for treating patients with Vabysmo?
Yeah. So I think, look, I think it's been now years on the market, right? And I think what you're seeing is this next wave of treatments, whether it's faricimab, whether it's 8 mg, you're starting to see them become first line treatments, right? Because I think we recognize that they work better, they work faster. We didn't even talk about time to drying, but time to drying in this trial was faster with faricimab compared to aflibercept. Let's call it like the older generation medicine. So I think that these newer treatments become first line, and so then the question, to answer your question, which is what's the protocol? If you can use them first line, it's hard to argue against it if you're really just looking at disease management. There's all the other, discussion points, insurance coverage, all that stuff. But let's say none of that matters. If you really just want to treat a patient, stabilize their disease, dry them faster, and get them extended out more quickly, you start with agents like this. So for me, it's a first line therapy. For patients that have been on other therapies, if there's a reason to switch, whether you want more durability, whether you need better drying, I mean, that's part of my protocol at this point.
What's the starting dose and how do you extend them?
This is a great question because even this is being looked at. So we've kind of historically like to do 3 or 4 loading injections, in DME, sometimes 6 loading injections. And if you go by the protocol, that's what you would do. I think in the real world for me, I'm treating monthly until the patient is dry, especially these DME patients. And then I'm pretty quickly extending them out. People will ask, well, you go out 2 weeks, you got 4 weeks. In this protocol, we were going out by 4 weeks, right? So I'm very confident and comfortable now extending out 4 weeks at a time versus maybe a few years ago where I was extending out 2 weeks at a time. So a patient comes in, they may get on average 3 monthly injections. They're dried out. Instead of in 4 weeks, they come back in 8 weeks. If they're looking good, go to 12, go to 16, and we extend out pretty quickly now.
This is a powerful drug. If the patient is dry at 1 month, do you start extending or do you
I,
treat
I
the
I have
beginning?
started that now. Yeah, and that's a change for me. Like if you would have asked me that question a year or two ago, I would have said no. I like to give a couple loading doses, but I think to your point, it is a powerful drug. We are seeing patients dry out very quickly, and we now have experience with those patients where we've extended them quickly, and they do just fine.
Yeah. Well, this is a significant advance in the treatment of diabetic macular edema, really.
Yeah, I agree. I agree.
So what's the next study to do with faricimab, do you think?
Yeah, so there's a couple of interesting protocols out there. I think the one that I'm kind of most excited about is called the Constant study. And Carmen, it goes right to your point about, can we extend patients more quickly, right? So I think we're kind of in this 20-year-old dogma of loading doses and how quickly can we extend. And that trial is really looking to challenge that kind of old thought process and saying, look, if a patient is dry after one injection, treat them again that visit, but then extend them out more quickly, right? So we're starting to see that thought process not only kind of in the real world, but now actually in the protocols that we're running. So I think that to me is exciting because I think that's going to give us more practical information, and it touches on the point, which is, hey, do we really need to load these patients up, or can we get them treated once they're dry, start extending them out?
Yeah, I think the clinical trials to maximize the result did the loading doses, but loading doses have been controversial since day one.
That's right. That's right. I mean, they're just kind of an arbitrary number we came up with. And they were. I mean, look, they work and the patients do well. And the counter argument is if you hit them very hard up front, are you going to get the payoff in the back end with better durability? And I think that's really what we're going to look at because we're going to really challenge that thought process now.
Well, listen, this was a great discussion about an important trial, and congratulations on your leadership in this program.
Oh, I appreciate it. And thanks for the platform to talk about it. I appreciate that, Carmen.